Thank you. I'm really kind of happy to bring telehealth into an audience of this many smart, influential people. Telehealth is important. It has moved from a niche thing, a novelty, to now it is absolutely center core mainstream in healthcare. That means that it has to be dealt with seriously, thoughtfully, intelligently, so that we don't just piss away yet another set of very important healthcare assets. Peggy, can you say piss away at the NCQA? I did it, so I'm in trouble. What is telehealth? Telehealth, the easiest definition is it is the use of medical information that is exchanged from one site to another via electronic communications to improve a patient's health. Well, what does that mean in real life? Well, there are about 5 major domains for telehealth today, and that will give you a sense. Number 1, they are involved in primary care interventions, virtual counseling and consultation. So when you see people connecting to their computer with their little the TV camera on your computer, talking to a clinician someplace remotely for the purposes of consultation and counseling. Patient triage. Should Mrs. Jones, mother of 3 children, living in rural Mississippi, have to get loaded up in the car and drive a gazillion miles to see whether or not that rash on little Johnny's hand is something serious or not? Let's decide now by using telehealth capabilities that, in fact, that really doesn't need to be seen by an ER. You can go home and cook dinner for your kids and do a very simple intervention. For medication management and prescribing, and then for chronic primary care, case management for things like diabetes, COPD, congestive heart failure. The second major area of telehealth is being applied is in consultations and interventions for specialties. There are extraordinary new tools now, new medical devices that will allow a cardiologist to auscultate the heart almost or just as good as if you were in the room with them. You have the ability now to listen to the lungs and do a pulmonology exam. The refining power on the cameras today is so good that you can do a very good dermatological exam. The speed and ease with which we have our video communications is so seamless now that you can have a legitimate psychiatric and behavioral health consultation. Surgeons are now employing this for peer-to-peer consultation. The third major area are in hospital-based things, connecting the ambulance to the ER so that all of the data is being pumped into the emergency room as the patient is arriving through the ambulance. The use of intensive care units being now centralized so that a patient comes in with a stroke in a small town hospital where there's no neurologist on board or they've not seen much stroke. Now you are seeing telehealth providers who all they do all day is manage stroke, seeing in a day more than most neurologists will see in a year. We're seeing also radiology has been a major stalwart for telehealth. And then as the patient moves from the hospital to the outpatient department, we're seeing a great deal in post-discharge management. The fourth area, in fact, is in the home. Wound care is an extraordinary burgeoning element here for telehealth because, again, you can manage the patient remotely because of, again, of the resolving power of the technology, having a home care aide in-house, but having expert consultation by an expert wound care person. Rehabilitation, another excellent home and community-based service. And then finally, wellness services, such as education, exercise and diet monitoring, as we heard earlier, health risk assessment, medication compliance, and even things like cognitive issues. As exciting as these tools and technologies are, it is always important to remember innovation for innovation's sake is meaningless unless it produces value. So the question ultimately becomes not to be seduced by new technologies, but seduced by the idea that the new technology can save lives, can improve quality, can drive up cost efficiency, and increase patient satisfaction. If you're not doing that, then what's the point? And so what are the problems that telehealth has got to resolve? What are the fundamental problems of our system? Number one, of course, the cost pressures. You know we're basically out of money. There ain't no more money on the federal side. There darn sure ain't no more money on the state side. There ain't no more money in large employers, and you know there ain't no more money for small businesses. So where's the money come from? From Mrs. Jones on 5th and Vine, and it's coming out of her pocket. And that's why Mrs. Jones is engaging increasingly in these technologies, because she wants to make sure that the things that she wants and needs are going to be affordable and accessible to her. The increase in consumer costs is 114% for family coverage since 2000. And you know that that's going north. And so people are going to need tools if they're going to be able to manage their exposure, their skin in the game. Second big challenge, of course, is the prevalence of preventable chronic illness. You know what that looks like. You know what the curve of preventable chronic illness looks like. We cannot possibly medicalize our way out of the burden of preventable chronic illness. It just can't happen. You already have too much coming at the medical care system that costs too much to treat it. And so if we can't turn off the spigot of preventable chronic illness, we are in deep doo-doo. Third, the quality concerns. The quality issues, of course, and I don't have to rehearse them with you here, but you understand how much waste there is, how much duplication there is, how much care is being delivered by people who are not on their game, and you know how many decisions are being made that are inappropriate. And so how do we begin to have technology and tools that help us to deal with that? We know that as we look at our challenges, we have a suboptimal delivery system. We have provider and supply mismatches. How do you get the young graduate today from medical school or the advanced practice nurses to move to little teeny town Mississippi? How do you get them to move to inner city Philadelphia? We have these huge mismatches in our supply side. And so how do we get care to people that need it? We have a fragmented delivery system. These chronically ill people need not only a plethora of clinical interventions, but they need also to be matched with a variety of medically necessary social supports, things that are within the community. How do you stitch that together? And now we are moving from this myopia of a fee-for-service reimbursement system to now one of population health, responsibility for total outcomes of care. How do you begin now to see that you can have tools and technologies that allow you to actually be relevant in a value-based reimbursement world? It used to be that we were on the clinical side focus on early getting that diagnosis and then managing that patient. If we can't do it, then moving them towards end of life and so forth. Now, when we get paid for value-based interventions, all of a sudden, the delivery system's got to come upstream. And now being concerned with the fundamental upstream things, the social determinants of health, the physical environment, the genetics of the person, the physiology of the person, but more important, the behavioral factors, the resilience, the spirituality of the individual. How does the delivery system connect that seamlessly back to the old stuff, which is really focusing in on all the clinical things? And so this idea of a value-based reimbursement world ushering in a population model demands and requires not only new information, but new abilities to connect across the continuum. Consumers are very much the focus and for telehealth, and the delivery system is very much the focus for telehealth. Let me look for a minute at the consumer side. People are still making an extraordinary number of suboptimal healthcare choices. They're not making personally appropriate behavioral choices or clinical care choices nearly as well as they should. And so we have to find a way to advance patient engagement for these personally appropriate choices. The consumer-directed healthcare plan movement has done a very good job of moving the needle forward. But most people who are thoughtful running health plans today understand that you've got to go beyond that the juice in the CDHPs is now basically squoze out, if you can say squoze out. I had a public school education, I'm not sure. So squoze is now a technical term, I'm told, and I can do that, so I invented it. People like United Healthcare and others of the insurers are moving to a new model of individual ownership of health, shifting a corporate culture from one that manages health benefits to one that encourages employees to maintain better health. And so telehealth becomes a very big and important part of being able to do that. Similarly, I'll come back to the delivery side in a minute. But as a result of the movement in this field, it has moved towards mainstream. Let me give you just a couple of sense of how fast this is moving and why the policy community has got to be all over this now before it gets much further. The ATA, the American Telemedicine Association, estimates that 15 million Americans received medical care remotely last year. That'll go up 30% in the next year. Health and Human Services estimates that 60% of healthcare institutions and 50% of all hospitals are currently employing some form of telehealth. Kaiser Permanente has published that they predict in 2016 virtual care, whether it's email, telephone, and video, visits will exceed in-person visits. National Business Coalition's Group on Health, large employers' recent survey on health plan design says that 90% of employers in that space will make telehealth services available to employees in states where it is allowed. And by 2020, virtually all large employers will offer telemedicine insurance coverage. Private insurers are moving rapidly, especially because 31 states now require parity for reimbursing telehealth services equal to if the person was in the physical environment. So looking to the future, consumers will have multiple opportunities to interact with health and medical care services in new and different ways. I thought the Walmart presentation was very good in the sense that we are really clearly seeing that there is going to be a true consumer retail market outside of insurance. Consumers will have a new kind of way of engaging, and will be commiserate with that new ways of paying for it, whether it is through the Apple Pay, Venmo, Bitcoin. All of that stuff is moving coincident with things and the tools and the technologies around telehealth, this consumer-oriented focus to be able to have healthcare start to move outside of traditional boundaries. This is going to be, I think, very, very revolutionary, particularly for what it's going to mean in terms of the implications for primary care. I won't have time to talk about that today, but just start to fast forward and think about it. The implications of this for the traditional patient-physician relationship will be profound. Patients will have a different relationship with their docs, and docs are being slowly accommodating themselves to this new reality. But it's going to be challenging if you watch and read the AMA, which, by the way, is actually getting much more progressive than a lot of us would have thought. I commend the AMA for trying to be thoughtful now about how do they manage this idea of the patient-physician relationship. But also telehealth on the delivery system side will also be very, very much transformative, because of the nature of the technology underneath telehealth that is moving so rapidly. Consider, if you will, the broadband and wireless technologies combined with new software designs. The Internet of Things is now being transformed in medical care to the Internet of Medical Things. This fantastic web and network of digital information that are now being joined together in a much more seamless way and with a very rapid adoption curve. Cloud computing and cloud-based image management and integration are game changers now. So the people that are doing telehealth have the ability to take their platforms and connect into the cloud and bringing images in and storing them and making them integral to the telehealth products, which is really, really now getting very excited about being able now then to address the comprehensive total clinical care needs of the individual. Advances in smartphone technology and miniaturization are huge. The resolving power of cameras, the next iteration of the people that are making smartphones, the next iteration of cameras even better than the ones today, and the ones today are damn good. at being able to take a skin lesion and be able to understand what's going on there. We're seeing advancements in sensor technologies, enabling innovation in wearables and in medical devices. We're seeing the growth of social networking. We are learning now that people's social networks may be more important at understanding the behavior of a person than their geographical environment. You want to influence someone's behavior? Yes, you still have to worry about physical geography, but also now it's the social network and being able to bring that in. Gaming technologies and artificial intelligence, very much a part of the movement for telehealth moving forward. And then transformative advancements in data aggregation and analytics, machine learning, being able to take the information from telehealth encounters and being able to make that something that it propels us in terms of the specificity of how we use that and engage. And then finally, innovation in how care is delivered in unusual places. And I thought, again, the Wellmark example was good. The kiosks. We're seeing kiosks all over the country now in pharmacies and other remote places that allow you to have really substantial clinical experiences. Does this stuff work? Is it being studied? Very much so, but not enough. But consistent findings coming out of a new ARC technical brief, which is very important. Systematic reviews now tell us very clearly that the benefit when used for communication and counseling for chronic conditions, for monitoring and management for chronic conditions such as cardiovascular and respiratory disease, and psychotherapy for behavioral health, unequivocally, this stuff works and it is good. Excellent primary research, but not yet at the level of systematic reviews, tells us that telehealth is working very well in consultation for acute and chronic management, acute ICU care, including remote monitoring and telementoring, and in maternal and child health. But we need a lot more research. So if there's one thing I could say to you that's important here, the policy crowd needs to get behind now much better support for ARC, more money so that we can have the resources and a better workforce to start to make sure that we actually are delivering value in this space. Let me close out by giving you a few what I think are key things going forward if this is going to be able to make a real difference in value. Number one, as in most things in healthcare, physician leadership is critical. The culture. I've had a lot of experience at putting telehealth programs into environments. The physicians are the hard ones to get to embrace because the early adopters got it, but the bell-shaped curve, all those people in the middle, they don't even know what the hell this is still. They don't get it, and it ain't in their normal comfort zone. And so we have a lot of work to do to teach physicians how to use these tools and technologies. Second, reimbursement is always an issue. It's everywhere it's pretty good. The people that are struggling with it is traditional fee-for-service Medicare. They just can't get their arms around it. But the people that are doing all the innovation stuff on Medicare love it and are building it into the ACO pilots and all of those sort of things, the bundled payments. It's in all of that, but traditional fee-for-service Medicare is a real issue. Third is coding. A lot of telehealth doesn't have codes. And if you don't have the codes, not only can you not get paid, but you can't do the research. And so we have a lot of work to do on coding going forward. Licensure is an issue. Licensure, as you know, is controlled by state boards. They're very parochial. They're very specific. Now, they're not bad people. If you are given the responsibility for protecting the health of the people where you live, you got to take that seriously. The thing that's so weird is the people in the medical board in Iowa do not trust the medical board people in Wyoming. We are good. They suck. So telehealth doesn't give a hoot about what state you're in because it's by definition trans-state. Geography and time are silly to telehealth. And so you've got a problem. So there's some work being done, and I think actually the Association of Medical Boards is actually working through this with a compact, which we hope will help to solve the problem. Liability issues, always the ugly head of liability issues has to be worked on. But the thing that I'm also particularly interested in as a rate-limiting step are the human factor issues. How do we make the telehealth tools fit seamlessly into the physician or the advanced practice nurse's regular workflow? And these are ergonomic issues, usability issues, comfort issues. We need the profession much more partnering with the engineers and software design people from the technology side and smash those together so that we actually can get products and tools that would be much more beneficial. Device integration and data interoperability is the big hurdle. You look at an emergency, look at an ICU now, picture of an ICU, and you got wires everywhere. The patient is with the bed, you got the wire to this, you got the thing machine, the beep, you got this thing falling, you got all kind of, this isn't even on anymore. Well, everything is broken. Technology is scary. The point being, all these different things are connected. So now once you take away the wires and you have everything sort of connected up, now the issue becomes, well, do they connect up? Do they talk to each other? Are they going to work in harmony or are they going to work in opposition? And then, of course, it's how do you connect all this stuff into the electronic medical record? ONC, are you here? ONC, are you here? We love you, ONC. We need you to have more people, ONC, so that you can do which I know is in your heart, which is, can we have an interoperable delivery, EMR system that can connect this stuff together? Please, we love you, and we need you to have money. So the Nixon administration, give ONC all the money in the universe. Device reliability and regulation. People in telehealth, especially on the mHealth side, who make consumer tools, do not like to have to go to the FDA for approval. So they try to slide under the radar and don't do medical grade products because they don't want to get caught up in that. But what's the point of having the products and the tools if you can't prove that they work? So we've got to find and make sure that our relationship with the FDA makes sense and that these folks are able, because you don't need products that are unreliable. You don't want a blood pressure reading that you can't trust in the clinical arena. Privacy and security will always be a huge issue. I will waste no time on it. And then I'll conclude with the last big issue is going to be performance measurement. Once these tools are inside of the delivery system, it will have a significant effect on the way in which we evaluate quality, because it changes some of the paradigms. And so what we'll need to start thinking about is, do we evaluate the telehealth intervention or just the outcome of a normal clinical delivery system with the telehealth embedded? These are going to be important challenges going forward. And the good news is that I see Peggy in the wings getting ready to come out, and I know that NCQA is really being thoughtful about it. So I conclude by saying this to you. This telehealth movement is now mainstream. The tools are, as I mentioned, across the board. They are complex, and they include a great variety of things that will make a significant difference to human health. We now need to make sure that we do not get caught up with innovation for innovation's sake. Innovation must always meet the criteria of delivering value. And that is the thing that we need you to be thinking about, how to apply this new armamentarium in an intelligent way that leads to better quality, better cost effectiveness, and of course, greater satisfaction with people with their care. Thanks so much.